right, so I'm sure other people will trickle in to join us in the coming minutes, but I also know that an hour is a precious and short amount of time, and also that Amanda in particular is under time pressure, so perhaps we might start off. So I'm Rosie Chadwick. I chair the Mint-House Board of Trustees. As I say, it's really great to see. Just a couple of bits of housekeeping before we get into the main content. One is to say that we are going to record the session to share with people who are not able to join us at this particular time. So I hope that's okay with everyone. If you don't want to be visible in the recording, I think most of it will be presentation slides, but perhaps you just turn off your secondly, we'd really appreciate your feedback on this event at the end, and Hannah will put up an evaluation feedback form in the chat towards the end. So it would be really great to get your take on today and other things you'd like to see, indeed. So without more ado, I was reflecting that it's hard to believe it's more than 2 years since Amanda and Kristina joined us previously to talk about the work that was going on to the Restorative Just Learning Culture in the NHS, but in Mersey Care NHS Trust in particular. And it was a fantastic event that I think inspired many. So we thought it would be great to ask them back, because many things have happened since, including publication of a book in which both Amanda and Kristina have had a hand, called Restorative Just Culture in Practice, Implementation and Evaluation. So we're really pleased to be joined today by Amanda, who's I don't think we got her title quite right in our blurb for the event, but she's Chief People and Culture Officer and Deputy Chief Executive for Non-Clinical Services at Mersey Care NHS Foundation Trust. Kristina has moved since we heard from her last. She's now lecturer in Management and Organisations at the Royal College of Surgeons in Ireland at their Graduate School of Healthcare. Because of the not being able to be in two places at the same time, which is a poor really. Anyway, Amanda will need to leave partway through, but she's going to be ably supported by the Deputy Director at Mersey Care Trust, Joe Davidson. So we've got sort of a galaxy of contributors, which is really great. Amanda, I think you're going to start us off, so over to you and many thanks.
Good morning. So good morning, everybody. Thanks very much for that introduction, and great to be back. So I've got some great colleagues with me. I've got Joe Davison, who's just been introduced to you, and also Dr. Kristina Brown. So Kristina, if you could click on the next slide for me. I think the first thing colleagues will know have heard me speak before, I always like to start a presentation off with a moment of reflection and to ask you, and please use the chat box accordingly, have you ever made a mistake? Hopefully I'm in good company and there's going to be lots of yeses there. But also importantly, if you made a mistake, you know, when was the last one you made a mistake? Was it last week? Was it last year? Was it small? Was it quite a big one? And how did that make you feel and the people around you feel? Because you could have also observed a mistake. So please share that with us. I think part of the conversation that we want to have with you today is, as leaders particularly, is about being aware of your own vulnerabilities and how that plays out in terms of how you show up as a leader, how you're present in the room, how you communicate, how you build or inhibit resilience. So really want you to think about how you contextualize that, how you utilize the language of mistake and failure, and colleagues will touch on that a bit later on throughout the presentation. Next slide, please. So, you know, it's really important, and if we had more time, we would facilitate this and have conversations about this. We could literally spend all day just talking about why is culture important and why it matters, and why employees' voices are so important in the design, the makeup, the fabric of the organisation, the DNA of how it operates. and how often you'll hear colleagues talk about culture being the soft and fluffy stuff. And if there's anything I want you to get from our conversation today, is it absolutely is anything but soft and fluffy, because it can be the thing that tips an organization's success or indeed failure. And the other thing we want to share with you is about how do you grab something so nebulous? You can't touch culture, you can't feel it, you can't see it, but you can, sorry, I should have said you can feel it when you go into an environment. So you work in a team, you might not be able to go, ooh, that's the culture there, but you will start to sense it. You'll start to sense it from how people talk to one another, or indeed don't talk to one another, how they raise concerns, how they give feedback, how feedback is received. Are colleagues able, and do they tell their boss bad news? So all those things will start to give you an indicative sense of what the culture is like. But fundamentally, it is driven by how safe colleagues feel. So to create the best safety culture in the NHS for our patients and our service users, we have to make sure our staff feel safe to work in some of the most challenging and vulnerable environments, and feel safe enough to be as candorous in that care delivery as what they possibly can, to give it their account and to tell the truth fully. And what I would say, certainly in our experience, is we have a duty of candour in the NHS, as indeed most regulated organisations do. But the question to ask is, how candorous are you? So are you 50% candorous, but the other 50% you may see, hear or experience, but you don't feel safe enough to document that, so it just goes to ground or it is unsaid? So we have to think about real psychological safety is the ability to be totally yourself in the room, have your voice heard, and feel that you don't have to be brought in, but you belong enough that you can be of yourself and give that feedback honestly, openly and transparently. And when you do, it will be heard. So just think about the levels of how that plays out in your organization. Next slide, please. So some testings about how you know what culture you have in organization. So some of the stuff that I've put down for hard data is on the left. Again, please use the chat box if you think that there's anything that we've missed in terms of what other hard data and intelligence that you have. So you might have other metrics within your organization that give you an indication of what the culture is within your provider or within your team. You've also got team referrals to the right, softer issues that often get missed or not considered. But again, think about those. And again, is there anything about what you know or experience within your organization that gives an indication of soft metrics at play? And the CQC often talks about something called closed cultures, and towards what that's saying to us as a closed culture is exactly the opposite of a restorative culture. Things happen, the unthinkable things happen, and you don't know about them. That's what a closed culture is. So my challenge to you is, how do you know the unthinkable isn't happening on your watch, in one of your teams, or one of your areas in your organization? Just to think about. It's constantly the test we ask ourselves. Next slide, please. So when we talk about restorative just culture, and I know lots of colleagues know a lot about this subject matter now, so I'm not teaching you to suck eggs, but it's just a reminder. We've used the academic of Sidney Dekker. I've spoke about that before. And the reason why that is the case is because Sidney focuses on a restorative aspect. A lot of organisations use an NHS incident decision tree approach that is shared. And whilst we have fed back and contributed to that, we think there's bits missing in that approach, the bit that happens immediately after an incident or event and what happens after. And there's also completely rewind it, why culture is so important. If it's not broke, you don't have to restore it. So what do you do to prevent breaking something? And that's, again, where the restorative aspect comes from, because you don't have to heal if it's not damaged or broken. So just think about that. But simply speaking, if somebody said to me, Amanda, what does restorative just culture mean to you? I would say it's about making sure that you can prevent the need to restore, but can restore it if there is a need. It's about being fair, you know, doing what's fair, reasonable, proportionate, the morally right, the justice aspect of it. It's that we learn post-incident and pre-incident. We learn from all the things that go well as all the things that don't. And we think about learning not just in a purest sense about fact and figures, but about values, behaviors, skills, preferences, all of those sorts of things. And accountability is also key. So whilst restorative just culture's definition of accountability is slightly different to the truism of accountability, I hold Amanda to account because that's in her job description. What you have to think about is accountability is two words. You have account and ability. And in other words, you can't hold me to account if I'm not being given the ability to be held accountable. So what abilities am I given through resources, through training, through development, so I am equipped with the skills and the resources to be held accountable? And in true restorative approaches, they're looking at forward-looking accountability. So something's happened over here, or we've prevented something, a near miss, we've had a good catch. What can we do to transform and translate that to make sure we're accountable for the future, to avoid the same thing being repetitive going forward? So that's kind of in a very simplistic way about how I would define restorative just culture. Next slide, please. So if we think about what's the opposite of restorative just culture, if there's an event or incident in the workplace and we say things like, who did that? What rule was broken? How bad did they break it? Oh, they didn't do this and they didn't do that. And we flow all sorts of bias at it, which is very, very easy, because when you say, I wouldn't have done that, I would have followed the rules, it's really easy when you've got the benefit of the outcome. When in that moment, they haven't got that. They're making decisions that are contextual in that moment with the resources, etc., that they have. That retributional focus, if you're asking those sorts of questions, is absolutely counterproductive to the cultures I believe that we need in the NHS and indeed across all sectors, because it inhibits learning. So imagine something happens and somebody says, right, Amanda, what did you do? Why didn't you follow the rules? Why did you do that wrong? Right away, the hairs on the back of my neck step up and I'm thinking, oh my God, I'm being judged for something I did wrong. So I'm not going to be really feeling safe, am I, in the giving of what occurred? And that's because often in those places, those retributional places, it can feel very dictatorial. It can feel very unforgiving, not really understanding of what's going on for me in my execution of my duties, definitely not focused on healing or humility. So I get all frightened, I clam up, and I either blame somebody else or I abdicate responsibility for what I need to do. Or I might not even admit that I've done it to the extent of which I have. That's what happens, and we don't get learning. Therefore, people in similar experiences with similar skills are likely to continue to do the same thing within your organizational culture if we focus an event in a retributional way. And it's dead easy to tip into. It's really easy to ask those questions because we've all been reared in that way, certainly in my age bracket anyway. So from a restorative perspective, you're asking a different set of questions. So rather than going straight for the who, you're trying to get to that what, reducing subjectivity, reducing bias and hindsight. You're trying to understand who's hurt. That could be patients, other service users or other patients. It can be yourself, team, colleagues, it can be the organization, it can be the department, a whole array of things. What do they need after that moment? You know, and that can be really, really variable, from support, you know, people being moved, people being retrained, having coaching conversations, or something really needs focus on in terms of putting something that's gone wrong right. And then who's going to do that? And certainly I think even today in Mersey Care, when things don't go how we plan to go, it's often because nobody's been assigned to make sure that they're looking after a person when there's been an untoward incident or an event. So who is it going to meet those needs? And we've got to make sure that we don't have single points of failure, you know. So things that have happened in our organizational history is somebody's been said, you know, Amanda, you're going to be that person's contact. You're going to communicate with them. You're going to keep them up to date with what's going on. And then Amanda goes off sick, but everyone's forgotten Amanda's being assigned to look after Joe. Sorry, Joe, I'm picking on you. So that it's that sort of thing. And that in itself, when things that you've agreed to don't go as planned, that can cause further hurt and compound issues and pressures. And we've also got to think about, it's not as blanket as it happened there, so it only affects the people that are there. It's about how that affects that wider organisation and the wider teams that are there. And if you think about what restorative approaches are really trying to focus on, that we engage with people from a supportive, fair, reasonable, restorative way, that we focus on healing people. And my experiences in incidents and of untoward events, we often don't heal people or support them, we hurt them a little bit more, both in terms of how we do the wraparound, how we support colleagues, and how we pull out that learning without the language of blame and fear. We also often think about that we can do all this stuff to our people, you know, whether it's an incident review, whether it's a patient safety learning review, whether it's a formal investigation, whether that's under patient safety or indeed under disciplinary procedures. We think we can do all of that, and then if we find no case to answer or somebody's been sanctioned and they're getting brought back to work on Monday, that our psychological contract is intact and the practitioner feels safe to practice. When you know there's all that stuff going on, you know, the rumour mill, no smoke without fire. Ooh, what did Amanda do? Oh, Amanda did this, Amanda did that. And it can be really hard for those individuals coming back into the workplace to feel psychologically safe, to be able to enact the duties that they've been trained to do when we've got all this stuff going in the background, which could be true, but it could also be fiction. And one of the lessons that we got a lot from Mersey Care's journey is when we went through this work, at best, we had individual and team learning. We didn't really capture the organizational learning. So if we had a whole plethora of issues regarding fraud, for example, I'm just saying something like that, we did it on an individual basis, not what was going on that we could examine and think, why is this becoming a thing? And I suppose my challenge is make sure you look at that thematic analysis to see, is there a trend? Because when there is a trend, if there's something happening, you might be able to put in different interventions. But if you don't look at trends, you won't be able to tailor interventions. So again, and that can go up and down. You can have spikes of things, dips of things. But as long as you keep the conversation alive about the learning, then you get into that preventional space because you're disseminating the learning, telling people, you know, say it's something like confidentiality. Remember, people, you can't breach patient confidentiality. This is why these are all the things that we do to ensure you're equipped with knowing you can't prevent it. We're just putting that as a reminder out there again. And that helps with nudging people in terms of best practice or appropriate practice in the workplace. Next slide, please. So I've talked about that really, but this is more looking at it in the restorative lens, what the goals are. So making sure people are engaged, doing the right thing every day in every interaction, looking at people when they need to heal. So if something has been broken, how do you help them with the guilt and the shame and the humiliation? How do you do that empathetically and reintegrate them back into the team? What do we need to do to help those people feel safe within that team? What do we need to do to think about the wider team content, because that they're being dipped back into? Because often the team's frightened, they don't know how to enact, they don't know, should they say, oh, we know about what happened? They're fearful too. And if you've got an individual fearful going into the team, fearful about receiving them, that's a recipe for disaster. So think about that as well. And the learning, not just thinking about the in-place learning. Is there some systemic issues that are going on with how you always do things like that within your organization that you need to change or redefine to make sure you don't fall over in similar times and places again? And obviously, making sure colleagues feel safe to speak up, tell the boss bad news without being blamed. And we talk a lot, psychological safety looks like this. People putting their hands up, being prepared to give feedback. If you say to everyone, does everyone agree? And you have that negative yes. So no one says they don't disagree, but nobody's telling you the things they're frightened of. So I have to tame that as you get a negative yes. People are kind of nodding along, but do they really agree with you? And as leaders, it's really important you get people feeding back to you, because if your style is very authoritative, then people feel less able to go, just Amanda, just breathe, pause, let's pull you back, let's go on and do something different. Just listen to this, need to reflect in on that. So it's really important that we embody that in not just what we say, but actually what we do. Next slide, please. So I am going to hand over now to Jo and Kristina, if that's okay, to take you through Mersey Care's journey. I know they'll be absolutely awesome because they both are. So great to be with you, even though if it was just for a small bit this morning. And I will love you and leave you, and I will leave you in their capable hands. And I've put my contact details and Twitter feed if people want to make contact in any way on there. So enjoy the rest of the session. Thank you, everyone.
Thanks, Amanda. So, good morning, everybody. I'm Jo Davidson. I'm Deputy Director of Workforce for Mersey Care. I have a particular portfolio. I'm responsible for organisational design, organisational development, and all the workforce education and training in Mersey Care. So, very much culture and restorative practice sit within my remit. I've been in the organisation for just on 12 years. So I've been here from the beginning and the development of a really ambitious strategy for perfect care. I'm just going to follow on from Amanda and give you a little bit of background, a little bit of context around Mersey Care. If Kristina, you could move us on to the next slide. Thank you. One before that, please, Kristina. Yeah, thank you. So today we are a large mental and physical health and social prescribing provider. We started life as a smaller organisation responsible for mental health care. We have one of the 3 high secure hospitals in the country, and we provide both inpatient and community services. If I just give you an idea as to how many inpatient beds we have, probably around about the same as a large acute, whereas over 90% of our contacts are in the community. Rapid growth over a period of years, some large acquisitions of other hospitals and some other services, including some of those services and development of growth into prison health. So very, very diverse. We are spread across a large geography in Cheshire and Merseyside and reach up into some parts of Greater Manchester and Wales and Lancashire for the provision of some of our care. So rapid development, rapid growth. We are about nearly 12,000 staff now, a bit more than what we're describing on the slide, nearly 12,000 staff, all professions, and I suppose in terms of our context, some of those organisations that we have acquired have been through our strategy to develop a biopsychosocial model, but also some of them we've been asked to acquire. They've been in a difficult place, requires improvement as a result of their CQC inspections. So not really of choice. And the staff have not always wanted to come to Mersey Care initially. So just some of that context and background against that ever increasing levels of demand and acuity. Thank you, Kristina. I think we can skip the next slide. It says a bit more. So yeah, from the very beginning, we've had a very ambitious strategy around care. We had a strategy for, I use the language, perfect care. And in that, we gave ourselves audacious goals around the zero concept, beginning with an ambition for zero suicide. We were the first trust in the country to do that. And we were pivotal in establishing the Zero Suicide Alliance. So that has been the basis of our ambition, and other zero concept audacious goals around restrictive practice, harm from medication, falls in our care, pressure ulcers, and now a really ambitious goal, not just to be inclusive, but to be actively anti-racist in our approaches, both for staff and for our patients and our local communities. We have a very clear co-produced set of values with an accompanying staff charter that describes both the helpful and unhelpful behaviours, co-produced with staff and patients, service users and their carers, their families, I have to say. So really, really important piece of work. So a very ambitious, espoused strategy for very best care, and the behaviours and the values of the organisation that underpin our culture development work. Thank you, Kristina. Next slide, please. I think colleagues will know that in the NHS, against that backdrop of ever increasing demand, acuity, constraints, especially during and after COVID, having exposed the fragility of the system, and with the introduction of integrated care boards, integrated care systems, it's a constant battle to balance focus around performance. We're a political system, we're public money, so there is regulatory requirements of us around performance. But what we work really, really hard in the organisation to do is to balance that focus with a real attention and commitment around organisational health. We're displaying the McKinsey model here, but how it translates into our strategy is a real prioritisation of leadership in the organisation, everybody, their collective, individual and collective leadership, and how that influences a psychological contract of every individual, and the culture that we create together, and really balancing that, recognising that performance is completely dependent on our ability to engage, support, develop and facilitate a completely different way of working in that ambition. So our strategy for best care sort of lives and dies on our ability to create that balance. It's a really difficult tension in the NHS, as you know. So really important for us. Thank you, Kristina. And one of the things you'll hear, if you ever hear my Chief Executive, Joe Rafferty, talk, when he's talking about just and learning culture and restorative practice, and that ambitious strategy for perfect care, one of the things that we had to do in the organisation is facilitate a shift around mindset and recognising that if we want to sustain collective ownership and collective leadership around really shifting the perception and the standards around mental health care initially, and then generally around all how care should be provided, both now and in the future, is that it starts with every individual. So helping every individual understand, have the insights around their role, their contribution, and how that starts to translate into behaviour and how we work together, rather than in previous arrangements where I think the organisation was structured to work in silos, teams. Great care is delivered through great teams and teaming across care pathways. And we had, in the very early days, quite a silo mentality. So really important for us to facilitate a learning environment, a learning organisation that actually starts with the mindset of every individual. Thank you, Kristina. So I've described an organisation that has been strategic and very ambitious in its approach to develop a different way of thinking around care, a different level of ambition around care, the highest ambition for its staff as well as its patients. And yet we got to a point where there was a great incongruence in the organisation. 2016 was a key turning point for us. And we just knew that something was wrong in the organisation. We had 3 inpatient deaths in one of our mental health units. We had some real dysfunction and disagreement with our staff side colleagues. And a number of key things happened around the same time that we said, right, we just need to pause what we're doing and have some conversations in the organisation with our staff, with our patients, with our staff side colleagues, key stakeholders. But this slide shows you what was captured at the time. So Amanda asked that question around anybody ever made a mistake and how did it feel? That's really important to constantly ask ourselves. In 2016, we asked our staff this question, and quite honestly, it was, how do you feel? And the powerful language consistently that was coming back, when things don't go as expected, bearing in mind in health is probably one of the most difficult places to work, places to manage. It's inherent with risk. And when things don't go as expected, our staff said they were fearful of the consequences, fearful of speaking up, fearful of being honest. I noticed somebody in the chat, I think Sarah Jenkins, said, that initial reaction when you've made a mistake, but it never leaves you. I've made mistakes myself more recently. Even last year, I made a mistake, and until I could come to work the next day and contact people, tell Amanda, let people know, I had that initial reaction of fear, of shame. I should have known better. I messed that up. And what are the consequences going to be? And this was a powerful feeling in our staff. So I'm the Deputy Director of Workforce at Mersey Care. I lead this programme of work. I have immense psychological safety with Amanda, the executive, the board, and yet a small mistake, a relatively small mistake, made me feel. So imagine how our staff were feeling when something so serious has happened, that fear that this generated, that feeling of shame. And we said, no, this has got to be the turning point for us as an organisation. Thank you, Kristina. So when we talked to staff, they said, well, we've got ambitious goals for clinical care, zero suicide, zero harm from medication, etc. But actually, we don't have one for us. And this is that turning point where, whilst we had prioritised programmes of work around culture and leadership and staff engagement in our organisation's planning, we hadn't actually gone as far as specifying or articulating this as one of those ambitious, audacious goals. And staff said, no, we need to have an audacious goal. They want to feel safe when they come to work. They want to be treated fairly and compassionately. So we convened a working group with a range of staff from all over the trust, with service user care representation, and we started to develop what was our initial strategy and objectives around what was then Just Culture. Thanks, Kristina. And this, and I'm sure colleagues will be familiar with the iceberg analogy. And this is what we wanted to get underneath. We said, you know, what we're actually experiencing is probably just the tip of the iceberg. So how do we systematize a really honest, safe conversation regularly across the organisation and develop an understanding where we have a collective ownership for the development of a different type of culture? And let's really specify what that different culture would be, would look like, would feel like, how that would translate into practice. So moving from that place where our staff had told us we were feeling like if things hadn't have gone as expected, that we would treat them punitively. Our policies, our processes were not conducive to the espoused values of the organisation. And we wanted to really examine that. You know, how does that incongruence manifest itself in what we had imagined to be the culture and the work life at Mersey Care, as opposed to the reality? And Sydney Decker has a terminology around it, work done. So really understanding work done as opposed to work imagined, balancing accountability with real psychological safety, not superficial lip service to psychological safety, but really creating that safe, supportive environment. And this is the work that we did in those early days. Thank you, Kristina. And in that accountability, looking at, actually, as Amanda said, if things don't go as expected, asking what happened, what were the contributory factors, what were the things that maybe the organisation can learn that they're responsible for, those themes, those systemic issues, as well as understanding maybe where the individual had contributed, not purely just focused around who in the first instance. And this is a major shift. It's been a real cultural shift for Mersey Care, but also pushing back against the wider system and really holding our own in this space to do this work. Psychological safety being absolutely key, and in terms of prevention and creating those safe spaces, that culture, when you're in that space, when things don't go as expected, and you can have the best restorative practices, but actually if people don't feel safe in the first instance, that you are not going to make them feel safe when things don't go as planned, when they have that visceral reaction to having made a mistake. So your initial reaction is completely dependent, if you are going to feel safe to speak up, is how this organisation treats you on a day-to-day basis, your relationship with your manager, with your team, and with your key stakeholders. Do you believe that you will be treated safely when things don't go as expected? Thank you, Kristina.
Jo, shall I?
Do you want to pick up from there, Kristina?
Yeah. Thank you, Jo, and thank you, everyone. It's great to be back with you again. So just very quickly, so I met Jo and Amanda in 2019 when I worked at Northumbria University, and we did a lot of work together on Just Culture, Restorative Just Culture, in the programme at Northumbria University. And I'm now at the Royal College of Surgeons in Ireland, but still do a lot of work with Mersey here and with Restorative Just Culture. So you might have heard that one of the things that Jill mentioned there was work imagined is work designed, and quite often a really important point of Restorative Just Culture and realising how our people work is quite often we can design processes, models, framework, which we expect them to use, and we can do it in isolation sometimes and in our ivory towers. But when they actually have to put these processes or, these workflows in actual practical experience on the ground, it can be quite different. And if the two aren't speaking to each other or they're done in isolation, we can also cause extra stress for our workforce on the ground, because we'll be giving them something to do that doesn't work. Hence, what they have to do is find a shortcut or a work around it which deviates from the written down process. But if they don't do that, they're not going to be able to do the job we're asking them to do. But if something goes wrong in them doing that, then straight away we've set them up to kind of fail. And straight away we're going to look at them and say, we didn't actually do what you were supposed to have done, what was written down here. They can't do it anyway, but we don't allow that fact to get into the HR processes that we'll maybe now use to discipline them or to do something else to hold them accountable. So it's really, really important that and this is what Mersey Care did as part of their work on this, understanding what it was like to actually do the job rather than just to design the job was really, really important. And I imagine a lot of you have seen that work imagined as work designed in healthcare a lot. So actually, Jo, I'm going to let you do this triangle because you do this one really well, I think.
I suppose this is just to show that in that broader piece of work, there's a lot of focus around restorative practice. But just to speak to that organisational health approach and organisational health model is that Mersey Care really do prioritise and seek to prevent, so to be proactive around the development, to be really clear about what we mean about culture and that work that we do and that collective ownership, but then develop the right policies, the right systems, the right processes, interventions, development programme, absolutely everything to front load to prevent and improve, innovate. But as we get into different circumstances, that we can respond and do respond in a restorative way. And I suppose it's just to balance up that attention. We talk a lot around the restoration, but for us, I think there is a major duty to look at where you can identify preventable harm and to continue to do so, have the dialogue and the mechanisms and the data that help you to continuously review that to identify and prevent that harm in the first place. Thanks, Kristina.
So the benefits of implementation, well, that's probably what it all comes down to, doesn't it? We put the time and the effort in because we want to see some kind of reward and investment in what we do. So I'm just going to take you through some of the challenges and benefits that came about with Mersey Care. What you'll find is that you'll probably identify with a lot of them, and not just Mersey Care, a lot of the NHS trusts that we've worked with, you know, in collaboration with Mersey Care. These are the common themes which come around all the time. So a lot of the challenges for senior leaders, one of the things that we found really important was, and there's a lot of questions that senior leaders have to ask of themselves, but they need to consider their style and impact. So what is their style of leadership? Are they really as aware and open as they think? And what kind of impact does their leadership have on people right now? Because I think, as we all know, don't have to be told that if, you know, this kind of work and the sustainability of this work really comes from the top. If you only have people on the front line who are trying to do this, they'll just burn themselves out, you know, trying to instill this in the organisation. So, you know, culture from the top and that leadership impact is so important, because if you don't have it, whatever people are trying to do from the ground up, it's just not going to last. So a lot of the time it was asking senior leaders to move away from their old way to a new way of leading, and there's a lot of vulnerability in this. And it takes a very open and authentic leader who is able to do this, because a lot of time, if you have all of the organisation looking at you and you are now going to change, you know, kind of the tack that you've had before, the direction, that takes a lot, okay? But you have to have that, you have to show that vulnerability to get people on board, and then they come with you. A lot of sensitivity. So we've said that before, you know, you might have leaders who've taken the organisation in one direction. They might have stood over when you have been managing or dealt with people in a very retributive way. And how are they going to stand up in front of people now and say, okay, we're not going to do it this way anymore. We realise that we have hurt people, but we're now going to change this way. And they can be very fearful of any kind of kickback or anything that's going to come that way. So they have to be sensitive to that. There's got to be that awakening and learning that there is going to be a switch now to fair and accountable in the learning culture. And as Amanda said before on one of the slides about restorative just culture and its definition, it's not about you know, anything just being accepted now. It's not about that at all. But you know, accountability is very different from blame, because that's where the learning comes. And when we have blame cultures, we don't have that learning that comes through. So that kind of awakening to the accountability and the learning is really important. Organizational reputation regarding leadership and the performance. I mean, you know, how many times do we hear now, if we look at all of the inquiries that we've had, not just into maternity recently, but, you know, inquiries that we've had before, when the organizational performance is put at the head of organizational health, then we always find that restorative just culture, fairness, accountability, learning is the first thing that literally disappears. And that's why we end up where we do, where we have patient harm, patient death, and it's really places that we want to avoid. And credibility and humility, massively important, you know, as when our leaders show us how empathetic they are and that they're humans like us as well, instead of suits that just appear when something terrifying is going to happen to somebody. It really goes a long way. So credibility and showing how humble and leading with humility, you know, is a real challenge that senior leaders need to get on board with. For the workforce, there was a number of challenges, and again, you know, these challenges will be there possibly on a daily basis, but it's more about how you manage them, and that possibly is not in the old way. So, you know, an acceptance that we all don't have our best day, we all have our blips. As Jo mentioned, you know, she made a mistake not so recently, you know, I can totally hold my hands up to that as well. But, you know, we have to accept we're not perfect, and it happens, you know, but it's how we manage that and how we deal and how transparent we are. You know, the workforce has to learn that it's got to be safe to raise a concern. So this comes back to that psychological safety that Jo was talking about. It goes back, it's a common theme in all of the kind of investigations, inquiries that I just mentioned. If you have a look at them, you know, even since kind of the early 70s and the 80s, always it will be, you know, staff weren't allowed to raise a concern. People didn't feel safe to speak up. And look where it gets us to. And quite often you'll find things like this, that there's a lot of writing lately from real prominent authors who will say that, you know, the biggest risk that we have today to patient safety is blame cultures and toxic cultures and poor teamwork, because it really is something that hugely affects. So when Amanda was saying, you know, this stuff is fluffy, please don't take it like that, it totally isn't. You know, this stuff constantly is highlighted and identified as the reason why we end up in the situation of inquiries and when, you know, we have patient death and patient harm. Empowered to catch errors again, so you know that psychological safety, it's all right to make a mistake, it's all right to be able to identify it and point it out, because we're not going to shame and embarrass someone, it's about the learning. And accountable but not punished. So again, we move away from that blame and we take it back accountability. Is there further training? Is there further learning? Is there further support? So, you know, all of these things for the workforce, you know, when things go well, when they cause harm, there's got to be a learning from that. Let's focus on the what instead of the who, because I can give you kind of, you know, a list of inquiries now that are still happening that in the early 70s and 80s, you know, we were asking ourselves, surely this will never happen again. We've had this inquiry, we're not going to blame people again, we're not going to take our eye off patient safety or supporting our teams, but it happens again and again. And improve the disproportionate experience example of BAME staff. So all of this is massively important. You know, Joe spoke about the anti-racism drive that they have in Mersey Care, but a lot of the times we've learned with organisations as well that if there's a lack of learning and a lack of support to deal with these kind of things, then they will still have the organisational processes that will drive certain staff of ethnic minorities to go straight to the blame end of things because people are too frightened to deal with it, rather than for them to be dealt in a much more fair manner. And for patients, also challenges as well. So, you know, patients have to recognise that all staff protect our values by doing the choices they make in their job. So, you know, our patients also need, possibly at times will need educating as well. You know, there's a risky behaviour as well that patients can show. And again, it's trying to, you know, work with patients, educate patients as well, so that our staff don't fall into a compromising situation with that. Reckless behaviour is not accepted by anyone, and there's good reason for that as well. And you know, when we work like this and staff have the highest morale and the motivation that they can to do their job, because as Joe said, it's a very high risk situation that we have people who train for a long time and dedicate their lives. You know, it's not just that 9 to 5, it's night times, it's weekends, it's shift work. So if we're going to ask our people to do the best with our patients, then we need to be supporting them for the best that we can as well. And lots of benefits, so lots of challenges, lots of benefits that come out. And of course, I think you've probably heard Amanda and myself talk about them the last time. Joe's mentioned them as well. You know, the organisation, that open culture, psychological safety, the boss can hear bad news. Transparency and openness are now our friends, and no longer do we see them as something to be fearful of when we go to work in the workplace. The sharing of good practice and stories is massively important. Storytelling, I think we've said this before, and I've heard lots of different trusts say that storytelling is one of the most powerful kind of vehicles you can have to get that good news, to share that good practice that we do. We're all human. Our people are definitely the solution. They are not the problem. And I think a lot of us sometimes don't see our people as a solution. We get into that daily grind of organisation life. You know, and again, that learning organisation, but I think it all starts, you know, of when something goes wrong, how do we deal with it? Are we too quick to jump in and blame and be very punitive, or do we just press the pause button and say, right, what happened here? What else was going on in the situation? How can we learn from this, and how do we stop it happening again? And policies and procedures, you might have heard and mentioned it before, but massively important. And co-production, always the way. If people feel as though they're being done to and not done with, then it just doesn't work. So in Mersey Care's position, they worked with the unions, which is really important from the start. They worked with staff, the staff drove the approach, came up with Restorative Just Culture ambassadors, and that was in kind of the staff and the patients as well. And the really important thing there I'm going to pick up on is the processes and the operational processes and policies as well. So as I said before, you know, if you want to create an organisation that is not looking to blame anymore, it's looking for people to speak up, to be psychologically safe, then you have to make sure that those back operational procedures are also in line as well. Because if you have people that then become very willing to speak up and put themselves in the spotlight as such, What happens if you still have outdated, non-restorative processes that are just going to take them down a blame route? Because not only will they be frightened, but other people will see that as well. So it's really important, you know, it's not just the way we do things, it's, you know, the way our organisation is set up, it's a real evaluation of our systems and processes as well. We're just going to tell you a little bit about the Mersey Care journey and what they, you know, really wish they'd known at the beginning. This is always a good learning journey for anyone. Jo, can you just very quickly take us through what you wish you knew at the very beginning of your journey?
Yeah, I think probably you've covered most of this, Kristina. I suppose in terms of that leadership and it is painful for some of those leaders to really accept and admit that this has happened on their watch, so to speak, as to use Amanda's language. I think it's really important if you are thinking about really supporting and demonstrating this at board and at senior leadership level. You help them with becoming vulnerable, genuinely vulnerable, and help them in that process. Every leader, that cascade, I think that's part of the learning, really expecting this to be difficult and ensuring that that support is there, that you can frame this work in a way that is absolutely essential for the safety in the organisation. The next slide, please, Kristina. And I suppose just to reiterate the point around psychological safety that I made earlier is actually balancing up that with accountability is really, really difficult in our sector. Invariably, people are looking for retribution. They sign up to restorative just and learning culture until they feel impacted, and then it's somebody else's fault or somebody else has hurt them, and then they're looking for retribution. It's taken us a lot of work and still does on a day-to-day basis, a lot of time and a lot of work when things don't go as expected, to wrap around the individuals in those circumstances to make sure that everybody is engaging with this process and is supported to engage with this process, to keep it psychologically safe for all, for it to be restorative, as opposed to in some circumstances where people absolutely insist on retribution of some form, as do, you know, a lot of the professional bodies. It's been a hard slog to champion in terms of professional practice, but we have persisted in that space because this is absolutely necessary. And you can see that in the NHS now, that understanding and that translation into different policy and plans. Long way to go. Even in Mersey Care, we share this work humbly. We've done some good work and made some good progress, but we're always learning, and we're always working hard to address the next thing and the next stage. So sharing with humility, really. Thanks, Kristina. Next slide. In those policies,
just before you go on, we're I'm conscious that we're out of our formal time. I hope people might have perhaps 5 or 10 minutes to hang on to sort of finish up, and
sure.
I know there are 1 or 2 questions in the chat, and perhaps Kristina, you might be able to say something about the Centre for Restorative Just Culture.
Should we just jump to some of the data then? You just jump to some of the data very quickly, Kristina. So just to sort of give you an idea, working as the practitioners and the provider space with our academic colleagues, Kristina, and the university, what we're constantly doing is evaluating. And one of the pieces that we have done in that evaluation is looked at the data to show impact and improvement, but also the economic case for doing this work. So we do have data that sits behind. What you can see is over a period where we have continued to have that rapid growth of those organisations that potentially are in a really, really difficult place. Their staff are in a difficult place. They didn't want to be acquired and, you know, taken over by Merseycare, that we have persisted in that work around engagement and development, specifically the culture, and we have seen a reduction, significant reduction in investigations and suspensions. And Kristina, if you skip to the next slide, you'll see that the time that we are spending is all of that front loading in those conversations. That things don't go as expected all the time in a risky, complex system, but actually how we've spent the time, as opposed to shifting into formal investigations, is having conversations and undertaking the learning. And in that economic case, that is supporting us to do all of the work that Amanda described at the beginning, and to support and restore and reintegrate practitioners. But actually, if your finance director wants the numbers, this in the data has shown it's average 1.7 million a year in reduction of legal costs, bank and agency costs, loss of staff time whilst they're suspended. So we can share that that detail if people are interested, to help them make the business case if that's where you're at in this process. And actually, next slide, Kristina, is even against the difficult period in the NHS that we've had with COVID, and with, you know, that rapid growth and complexity, we track through our staff survey people's willingness to speak up. It's one of the most important things for us, going back to 2016, when staff didn't tell us or feel able to tell us the reality, as in terms of when things don't go as expected, let alone have that learning. So I'm just conscious of time. Kristina, if you wanted to jump to your last slides.
Yeah, I think we probably told the story very well, but you know, what we would say to everyone going forward is, you know, if you're looking to do this, you know, it's really good to have kind of a working group, establish a lead that you're going to have for this. You know, look at what your key objectives are. A lot of this comes from, you know, looking at your data, gathering some data together, NHS surveys, operational data you already have, do some qualitative exploration. Look at what the key issues are, decide on, say, 1 or even 1 to 3 objectives which you think you can tackle, which also align to corporate strategy as well. And then, you know, start to establish that delivery group, a term of reference, look at what your evaluation metrics might be. And, you know, and even if you only start with one of these, one of them can do a lot of good work. And then you'll kind of look, you'll start to have all of the benefits that Joe and I kind of mentioned there as well. And the last thing I would probably say is, you know, we did a lot of work with Northumbria University. Northumbria University still run the Restorative Just Culture 5-day programme, which takes you through the principles and practices. There are also development sessions for the board, which is really important, and there are 1-day processes as well, or 1-day classes. So that's the masterclass on teams, implementation and business planning, HR policies, and just the 1-day masterclass itself. So thank you very much, everyone. I'm sorry that we went just a little bit over on time, but we're just very passionate and could probably talk for weeks about this stuff. Joe, do you think?
No, thank you, Kristina and Joe. That's been absolutely brilliant. And as somebody said in the chat, the statistics are a wow and really powerful. Just before we wrap up, Kristina, do you want to say anything about the Centre for Restorative Just Culture?
Yeah, it's something that it's not quite live yet, but this is an idea that was had about creating something for organisations where we could put a lot of resources and a lot of help for organisations to have free access to help them on their restorative journey. And it's really just a like-minded place for anyone who's trying to do this journey to have others who are coming through it with. We do also offer where we can help organisations with this, but we expect a lot of that to be coming out very soon, Rosie. So thank you for giving me the opportunity to mention it there. And you know, we'd be delighted to share it with you all once we start to get going on that. But it's really just to help us and to help people like you who are really interested in kind of going on this journey. Yes.
Thank you, that's brilliant. There were just a couple of questions in the chat. If you've just got a minute to just see if we can address them, and then we'll perhaps aim to wrap up at 10 past. But one is from Joe Power. I'm aware of a situation where a family lost their father in hospital in circumstances where there was an unreported fall. The family have overwhelming evidence, including photographs and inconsistencies in records, but the health services admitting nothing, and it looks like going to court. Are there any situations such as this that have been dealt with restoratively, and how do you protect staff in situations where revealing errors could leave them open to disciplinary action?
I would say that in a circumstance where we have a serious untoward incident in Mersey care, then we would follow one of the slides that we've skipped through. Is one of our processes is before we actually commence an investigation, we have what we call a 4-step process. It's in the process of being reviewed at the moment. There've been several iterations of this, but it gives us a series of questions to ask before we commence a formal process. And part of the questions asked is to say, who has been harmed? So that will be a patient, their family, the staff member, the team that have been involved or on that ward, and all of those individuals, all of those stakeholders will be contacted and supported in that process, so that all of that information and all of that data, and the approach absolutely is to restore, repair, to learn.
Thanks, Joe. Thanks, that's helpful. And then the other question is, I worked for 20 years for a mental health trust. The mood music at the top was great, but lower down it was punishment and shame. How to get the message throughout the management system? Any reflections on that?
Absolutely. So quite as part of your strategy to support this, two key aspects of strategy, I would say, is around your leadership model and the rigor around the leadership and management development right through the organisation, the cascade of that, the oversight of that, and the alignment of your leadership with the strategic aims. So we give ourselves objectives and measures around that every single year, as we do around team health and the systematization of development and infrastructure for every leader and every team to facilitate that culture, apply this in practice. And we have measures around that, indicators and measures around that as part of a dashboard, but very much aligned to clinical quality assessments as well. All aligned to closed cultures, CQC, well led. There's very robust infrastructure and development that we build on every year to improve, that supports every manager, every team, every individual in that team to really understand this and to understand their role and accountabilities, have the development and support of the capability, and be really clear about the behaviours that are acceptable and unacceptable in that staff charter.
Thanks, Joe, and thanks, Kristina, as well. We really are now out of time, but somebody who's posted in the chat have to leave to attend another meeting now, but inspirational to hear about the Mersey care journey, and it has been inspirational. So Thanks very much. That's been
Many
fabulous.
thanks to
I hope it can be
everybody.
okay to send around your slides, because I'm sure they'll help equip others to make a similar case and progress their own case, and also details of how to join the virtual community support that Mersey Care facilitates.
Absolutely. There's so many resources and, you know, community right across the NHS having these conversations regularly, learning from each other and sharing. You're very, very welcome. We will send the link so you can share that as well.
Lovely. Thank you very much, all. It's been
Thank
brilliant.
you.
The evaluation form will come very imminently. Yeah, we look forward to seeing you all again at some future point.
Thank you so much,
Thank you,
everybody.
everyone.
Take care. Have a great
Bye.
day.
Bye.
Bye-bye.
Thank you.